Hello students, how are you all? I am Dr. Ramakrishna Chaitanya, consultant anesthesiologist, critical care specialist, and your anesthesia faculty at Marrow. So, welcome to this module of INI-CET 2023 recall session. So, how did the exam went for you? Yes, we are getting some mixed reviews from the students. Some students are saying it's good. Some students are saying slightly tricky questions. Not a lot of PYQs came this year. You need to think at some areas. As usual in anesthesia, the weightage was around 3 to 4 marks. So out of which purely anesthesia related questions, if you ask me, there were around 3 to 4 questions, which we are going to discuss in this session right now. So there are some questions, yes, this will be covered by other specialties, like, some surgery. So there are some mixing up of questions. So I don't want to mix up all the questions and put it under anesthesia and tell to you that everything is coming from this. So those which are clearly indicating towards the anesthesia side, I am putting it. Some questions which are mixed with it, the concerned specialist or the concerned faculty will be talking about it. So without wasting much time about it, so let us start this discussion session, INI-CET Recall March 2023. Okay, so what's the first question that came today? So a patient who came to emergency care with an acute pancreatitis was shifted to ICU and intubated. The ventilator settings are, okay, the ventilator settings, I'll highlight few of the important points. The ventilator settings are FiO2 is around 90%, the PEEP is 12%, respiratory rate is 16, okay, fine. An arterial blood gas analysis showed PaO2 of 110 millimeters of mercury, PaCO2 of 58 millimeters mercury, right? Fine. What would be the next step in management? Right. Now, this, if you ask me, this question is slightly tricky. Yes, it's a lengthy question. The moment many students, they said, with the moment they look at the ventilator, it gives them slightly tachycardia. Yes, because during an internship period, we don't get exposed towards the ventilator. But what we did in this Marrow module of Edition 6 is I especially concentrated on one session entirely on ventilator settings, how to keep the settings, or what to look forward it. So in that session, I clearly mentioned that when we are keeping a patient on ventilator, our main goal is to keep the patient in normal physiology. So we have to maintain the normal physiology for ventilator related things. I am again specifically telling you that please maintain the normal physiology for this patient, normal physiology. This is what the goal, right? Ventilator is an equipment. Most of the students, they get really panicked because we don't work with it. But especially if you understand the physiological concepts of it, then it would be very easy. It's a simple machine. Okay, so here the question, unfortunately, there are some variations from student to student. Actually, I have taken an average value of it. Some students said some other points, some students said some other points. So at the end of the day, whatever I made conclusion from the students review, because basically it's a review session, right? So what I made from the conclusions, I have put this question like this. Okay, so what they are asking is, this is a patient of acute pancreatitis. Acute pancreatitis. I'm just summarizing the case. This is the case of acute pancreatitis and a patient is on ventilator. So what is happening here is the patient weight, some students said it as 70 kg, some students said it as 50 kg, but I think it's 70 kg. Let us put it like this, 70 kg, right? So this patient is on ventilator, and here two parameters he has clearly mentioned. One thing is the patient saturation is 100%. This is one key point here which we need to understand. The second parameter is here they have set the ventilator of 420 ml, right? The PEEP of around 10 centimeters. Some students said 12 centimeters. It's fine. 10, 12 centimeters. Respiratory rate also, some students said it is 12, some students said 14, some students said 16. Okay, any other number between 7 to 16, right? So what are the other things which we are monitoring? So when we are keeping a patient on ventilator, we are taking an ABG, and the ABG analysis, they have mentioned pH 7.33, right? The pH is mentioned around 7.33. PCO2, they mentioned it as 58. Some students said it is 48 also. Fine, 58, 48. Okay, bicarbonate, I don't know exactly have they mentioned it or not, I don't know. because there is some amount of ambiguity, because it's very difficult for the students also to recall all the things, especially students like me. They don't want to recall after the exam session. Okay, fine, leave about myself, right? So like, what is the next best step in the ventilator of the patient? Okay, now looking at this patient, what are the clinical diagnostic points we are getting? So if you look at this question, see here, this is a patient of acute pancreatitis. That means acute pancreatitis, we all know that the patient can develop into an ARDS like picture. So the patient can develop into an ARDS like picture. So I'll change and I will write it. So he has developed some ARDS picture or something which might be associated with ventilator, or something like ventilator associated pneumonia, something like that. Okay, some students said it's a pneumonia case also, right? Fine. So I am writing the two possibilities, right? Most commonly, it will be like ARDS picture will be there. So what we have done in this routine session is we discussed keeping ARDS patient. Um, I don't say I have covered everything about ARDS in the small session, what I made it in the video lecture. But yes, I have covered the basics of ventilatory strategy, because, in the COVID, we had a lot of ARDS patients. So I kept COVID patient as a reference, and I talked about in the edition 6, we talked about the how to manage this COVID patient when a patient is on ventilator, apart from the modules, apart from the repeated respiratory sessions, respiratory physiology, etc. I talked how to manage an ARDS patient. So more or less the same things apply here also. Only thing is, in COVID is more infectious. This is not that much infectious disease, right? So this is looking more like a ARDS picture rather than pneumonia picture, right? So this patient is having ARDS like picture. He's maintaining a good saturation. I don't know what are the other vital parameters. They mentioned anything? Pulse rate, blood pressure? I'm very clueless here. Okay, pulse rate, blood pressure, I don't know. Whether the patient is sedated or not, we don't know. So there are so many missing links. If you ask me, if you this question for an examination point of view might not be a good question, because we cannot come to one conclusion. But at the end of the day, here we are not coming to conclusion. Here the examiner particularly wants you to know few of the things, the basics of the ventilator settings, or the basics of the respiratory physiology. This is what I felt by looking at this question, rather than coming to a diagnosis, changing the ventilator. So what he's looking at here, it is looking very clearly that he wants to look at the whether are you understanding the concept of ventilation in a patient with ARDS or not. So that's what is his thinking, what I presume to be, right? So here the patient is ventilated well with 6 ml per kg. If you are taking 70 kg person ARDS patient, I said the ventilation strategy, we have discussed it very clearly, that it is like, we call it as low tidal volume, high respiratory rate. We have to keep it as low tidal volume, high respiratory rate for the patient, because I don't want the alveoli. The problem is with basically with oxygenation. And in patient with ARDS, our goal is not always to maintain a saturation of 100%. My goal is not this one. What is my goal? My goal is to maintain somewhere between, I'm happy between 92 to 96. I'm very happy. Actually 94, 88, 92, all these numbers are very happy for me, rather than keeping a patient on 100% ventilation, right? So ARDS patient, my patient goal is around 100%. Is not so very good. My strategy of ventilation is to keep low tidal volume, high respiratory rate, and very important is I am relying very much on my PEEP to provide oxygenation, to provide oxygenation for the patient. Okay, so I am happy because I want to maintain the PO2 within the normal range. So if I am saying within the normal range, you should be knowing what are the normal ranges. Obviously, it's a very basic thing. So what is the normal range of pH? 7.35 to 7.45. We call it 7.35 to 7.45. PCO2 is between 35 to 45. Bicarbonate is 22 to 26. Here we didn't get any information about bicarbonate, but here there is one more thing which I have particularly stressed in ARDS patient. My goal is not to maintain 100% oxygenation, and also not to maintain normocarbia also. There is something called as permissive hypercapnia. Permissive hypercapnia. Hypercapnia. So where I can wait till the carbon dioxide levels in the body can get accumulated up to normally around 35 to 45. We can keep the carbon dioxide between 50 to 60 millimeters of mercury also. Okay, I am happy if the saturation SATs of my patient is maintained somewhere between the saturation is maintained somewhere between 88 to 92, something like that. If we maintain, that is fine. Here we forgot to write one important point. What they have said, it is PO2. PO2 is 110 millimeters of mercury. Okay, so PO2 is 110 millimeters of mercury, and what is the normal value of PO2? The normal value is 80 to 100. Right, so here there is something called as permissive hypercapnia, where I can wait the carbon dioxide to be accumulated. Right now, this is the typical thing what we follow. Whatever we did in COVID, the same thing we have extrapolated, the same, more or less the same thing from the ARDS pictures only, because what we are seeing in the COVID is the same thing. So what we have done is we are following the same guidelines. Now, if you understand that this is a patient of acute pancreatitis and they want the ARDS picture, they are talking about the air. They have not mentioned it, but we are presuming to it, right? So here, if you look at it, the patient is getting a good tidal volume 6 ml per kg. That's a low tidal volume, right? 6 to 8 ml per kg tidal volume, 70 kg person. That means, yes, this is okay. PEEP is around 10 to 12 centimeters. They said, fine, this is also a good strategy of ventilating a patient. So I am happy with this. Respiratory rate is 16. Some students said 12, 14, 16. But still, as I said you, this carbon dioxide levels are maintaining well within the normal range. Yes, slightly higher range, but as I said you, it's a permissive hypercapnia. So I am happy with this respiratory rate. But here I am not very much happy with the saturation values. Why I'm not very much happy? As I said you, this is an ARDS picture. Here my target is not to maintain 100% oxygen, because on prolonged ventilation, there might be production of oxygen free radicals, and this might aggravate my lung injury, right? And here my target is not to over ventilate the or over distend the alveoli, because if I start over distending, it will cause more sharing process on alveoli, and it will increase the more amount of damage to the alveoli. So this is not my target. So here saturation is 100%, and if saturation is 100%, I don't rely alone on saturation. As I said you, every time when I keep a patient on a ventilator, one thing which I have to look at is the ABG, and in the ABG also, see here the PO2 values are 110 millimeters of mercury. That means compared to the normal range, they are slightly on higher range, right? So if it is on higher range and my target is also not 100%, so obviously I have to reduce the FiO2, because here, see here, the FiO2 what they have mentioned in the question is the FiO2 what they have mentioned in the question is around 90% or 0.9. See here. So if this much amount of FiO2, if I am keeping, the oxygenation is actually, for a normal patient, it should be very high. 200, 300 you will get. Here, typically, it is an ARDS picture where PaO2 by FiO2 ratios will be on lower side. But still, the PO2 is on very good range with that FiO2. So let us see the options what they have mentioned. So reduce the FiO2. Yes, this is looking a probable option for me, because still it's on a higher rate. Reduce the respiratory rate. As I said you, if I keep the respiratory rate reduced also, there is no point, because my target is between still 50, 55, 60. I'm happy with the patient. Okay, unless otherwise the BP is there, the patient is fighting with the ventilator, then I'll be thinking over what to do. But I will not reduce the respiratory rate. My target in ARDS picture is permissive hypercapnia, so I'm not reducing the respiratory rate. Increasing PEEP again. If I reduce the respiratory rate, what will happen is carbon dioxide is washed out, which I don't want, because I'm happy with the carbon dioxide value. If I increase the PEEP, what will happen is it will improve the oxygenation. PEEP is for alveolar recruitment, so it improves the oxygenation, but already the oxygenation of this patient is also very good. SpO2 is maintaining good, PO2 is on higher sides. Again, so PO increasing the PEEP will also not be a good option for me. So increasing tidal volume. So if I increase the tidal volume, just now I said you, it will increase the sharing forces on the alveoli, and it will promote more toxicity or more damage to the alveoli. So increasing tidal volume is also not a good option. So out of all the things, what is the best option? Reduce FiO2. So when I was a student, I had a very strong feeling that I should not reduce the FiO2. But I said it in the classroom. I made a session. There's, at the end of the day, oxygen is a drug. Okay, although we are giving it, most of the times we don't use it properly during our application for the patient, but oxygen can cause more damage if you don't use it judiciously. Okay, so I made a session on the regular videos where I have talked about the oxygen therapy. So if you have not watched the session, please watch that session. So what I recommend to the students, basing on the previous year, because 2 sessions back there was also a similar kind of questions on ventilatory management. So on this basis only, I am recommending the students to watch 2 videos. Make sure that you watch the oxygen therapy for the patient, which we have discussed in detail in edition 6 video. And also there is one thing which I have discussed is the ventilation strategy, ventilatory settings, where I discussed the normal respiratory physiology, its clinical application of the respiratory physiology, and also how to various modes and taking COVID patient into the reference. Okay, so these 2 videos are must to watch because basing on the previous questions how they are framing it. So very important is this kind of questions. Yes, slightly tricky, but for this you need to have a strong basis of the physiology so that you can answer this kind of question. But at the end of the day, if you have seen that video, we have stressed that whenever we are keeping the ventilator is not the treatment. Ventilator is to maintain the normal perfusion. That's what I said it. So if you look at the question, read it, think it for a moment, 3 to 5 minutes, 3 to if you wait for 1 to 2 minutes of time, just think over what is happening, make some calculation, then obviously you can understand that the patient is having high PaO2, and that's how we have to reduce the FiO2. So that's a clear answer. So answer is reduce the FiO2. So this is the first answer to the question which they have asked. Shall we move to the next question? Right. A CPR is said to be of high quality when there is which of the following. Again, the same standard set of question. Every year they are asking one question on oxygenation or ventilator therapy. The second question is minimally they are putting on the basic life support for the patient. They are asking about basic life support. We have again made this session, entire session. I don't say I have only made this session because basic life support of late from 2020 I have been seeing this question every year. Basic life support and advanced cardiac life support. So this time they have asked a very simple straightforward question in basic life support. What is the correct statement? So if you remember, if I just go through it very superficially, whenever a patient is not having pulse, so how do you identify the pulse? Check the carotid pulsation. Again, I said you carotid central pulsation less than 10 seconds of time. If you can't feel the pulse, immediately start chest compressions. Start compressions. How many compressions you have to give? It's very obvious. It is around 100 to 120 per minute. 100 to 120 per minute. You're not less than that, not more than that also, right? And when you are doing the chest compressions, you should do the compression at the lower 1/3, okay, in the 1/3 of the manubrium sterni, and you have to compress a minimum of 5 to 6 centimeters of depth. It should be there. You should allow adequate recoil of the chest wall, and you should minimize the interruptions. So we made a beautiful chart. I have not made the chart. That I have copied it from the American Heart Association basic life support. So that chart we have copied it and kept it in your notes also. So please, if you have not gone through that thing, so please go through and see it. So one thing which I made it very clear, whenever we are doing the chest compressions, what should be the ventilation and compression rate? So the ventilation to the compression rate should be 30:2. That means 30 compressions, 2 breaths. 30 compressions, 2 breaths. You have to do it like this. So unless and otherwise there is an advanced airway. So advanced airway means either in the form of LMA or in the form of endotracheal tube. So where we need to reduce the breath rate to 8 per minute. Fine. So here, what they are asking, which of the following is not a right statement? Chest compression should be around 100 to 120 per 2. This is the right statement. CPR is said to be high quality when there is which of the following? So 100 to 120 per minute is a good one. Breathing rate at 20 to 25 minutes. Yes, this is 20 to 25 per minute. This should not be there. The breathing rate already we discussed it should be around 30 to 2. Depth of compression should be around 5 to 6 centimeters. Again, this is the right statement. Allow complete chest recoil. This is also a right statement. So pretty straightforward question. So this is most of the students, they marked it correct. So out of which one is correct? 1, 2, 3 or 1, 3, 4 is correct. Okay. So read the question properly. That's what is the take home point of it. Though it looks simple question only, you should not do the silly mistakes for this kind of question. Okay, read the question properly, choose the options, because there are 4 options. Again, you need to look at the options and you have to decide 1, 2, 3, 4. So don't be in a hurry. This is one thing which I wanted to stress here. Though it looks like a simple question, some student, 1 or 2 students, they message me, sir, silly mistake we have done. So just I wanted to make sure that when you are looking at the question, read it with a very cool mind. This is what my suggestion is. Every time when I take a class, the moment you look at the question, if your eyes are not trained to look at the question, that's what we say when we are doing our sessions like marrow links or etc. We ask the students, why do you think we ask the students to do practice more MCQs? If you practice MCQs, what happens? Your eyes are trained to look at the MCQs. Okay, at the end of the day in the examination hall, if you look at CPR, the moment you say CPR, yes, CPR. Okay, you should not do a silly mistake, because this majority of the students, they will put it right. One small mistake, your rank will drastically drop down. Right. So when you look at the question, when you practice the questions, what happens is you are trained to look at the question properly. Your mind will not be hyper excited or it will be depressed. So this kind of question, if you look at the previous question, this is a depressing question, right? If you look at this question, this is a hyper excitable question. I don't want a hyper excitable state, or I don't want a depressed state from your side. I want you to look at, if you are hyper excited, the moment you look at the option 2, 3, right? Yes, option A. Many students, they get this mistake, they do this silly mistake, right? So if you are depressed, you don't read the question properly, sir, this is a very lengthy question, I don't know about ventilator. But so I want your eyes or your mind to be trained in such a way that you look at the question, make a clear consciousness picture, and you do this answer. Okay, so that's what is the take home point, and this is a very standard question from the anesthesia point of view, basic life support. So please go through it if you have not watched that video. Okay, shall we move to the third question and see what question they have asked? Right, in a patient with thrombocytopenia, platelet transfusion is done when the platelet level drops to a threshold. To proceed with surgery, platelet transfusion is done to achieve a platelet level of. So in simple words, if you ask this question, many students have recalled it as, what is the minimum controlled or threshold value where you will give platelet transfusion when a patient is scheduled for surgery or any invasive procedure or invasive monitoring? What is the minimum threshold value? Now, we made a session in pre-anesthesia checkup. We made a session called as pre-anesthesia checkup. In pre-anesthesia checkup, we covered it under 2 headings: evaluation, preoperative evaluation, and preoperative preparation. So evaluation, we all know that which drug need to be stopped, which drug need to be modified, which drug continued, all these things we discussed. In preparation, we talked about there are 4 components of preparation. The first one is investigations. What is the second one? The second one is optimization. The third one is pre-medication. The fourth one is consent. So no one will ask you about the consent. Yes, in investigations, I said it very clearly. Whenever we are planning for any surgical procedure, we will get the basic investigations done, and we should know all the basic. Why are we ordering an investigation? That's what is the basic question which a student should know. So this is a very common practice to order an investigation that is called as CBP. In CBP, we will look at 3 things. One is hemoglobin, the second one is total leukocyte count, and the third one is platelet count. Right. What is the minimum cut-hold value? So what is the normal platelet count? First, you have to know that, right? So everyone knows this one. This one is around 1.5 to 4 lakh. So when will you order platelet transfusion for a patient before coming to a surgical procedure? So we discussed later, whenever we are planning for surgery, we are comfortable if the platelet count is more than 1 lakh. But that doesn't mean that whenever the platelet count is less than 1 lakh, you have to go for platelet transfusion. So this is what you learned in your medicine, or I also said it many times. Whenever the platelet count drops to less than 20,000, even in dengue patients, right? You will not give, if the platelet count is dipping, we will not give platelet transfusion, because at the levels less than 20,000, then only there are chances of spontaneous bleedings are there. So we will transfuse platelets only when the platelet count is less than 20,000. So up to which level, when we are planning for an invasive procedure, we can take up. When we are planning for an invasive procedure or a surgery, we will be happy, if the surgery is an emergency and the platelet count is dropping, when will we be giving? So there are some reports, I said you, we will do generally for an elective surgery, 80 to 1 lakh is the cutoff value. But that doesn't mean that we are not transfusing it at 85, 88, etc. There are some reports there we have done successfully surgeries, or we have done successfully invasive procedure if the platelet count is around 50,000. So minimum for any surgery or an invasive procedure, 50,000 is our target. So below 50,000, when we are transfusing it, we will make sure that the platelet increases up to 50,000. Then we can plan for surgery. If it's a purely elective surgery, yes, depending on the which site we are doing surgery, what type of surgery, whether it's bleeding or how surgeon is comfortable, etc. So depending on it, we will decide it. So what is the options they have given? So obviously 30,000, yes, we are not going to take up for any elective surgery. That's not a very good option. 40,000 is not also a good option. Yes, 50,000 is a good option. So there are some reports where they have said, like, okay, 50 to 1 lakh is that's a borderline range. Okay, that's a borderline range where you can take up for surgery. Yes, ideally 80,000 to 1 lakh is for any invasive procedure or any surgery. We are not going it. But if we are transfusing it, we will make sure that the platelet count is around 50,000. Okay, so more than 50,000 is a good value, so that you can do invasive procedure and there will be less chances of bleeding also. Okay, that's what we discussed in this chapter. So more or less straightforward chapter. So as I said, one question of late most of the examiners are interested is about pre-anesthesia checkup. In pre-anesthesia checkup, very importantly, the pre-operative preparation of the patient. Okay, please go through that module in detail. We have discussed about the pre-operative module, how to prepare a patient for surgery. Right. The fourth question. Again, I couldn't recall it properly, but what was the question? I don't know exactly. A 15-year-old boy reported to emergency with breathing difficulty, and the image of ECG SpTO2 was shown on the monitor. Both of them are looking normally, but some students, they said the capnographic image was given and something like sharp fin pattern, something like this pattern. So this was the sharp fin pattern, something like that. They are mentioning it. I'm not very sure, because some students, they said it's a case of viral myocarditis. I am not very sure if it's a viral myocarditis. I don't know. Yeah, why breathlessness? I couldn't get the proper recall of this question. Apologies for that. But some students said it's a capnographic waveform they are mentioning, and there is a sharp upstroke. This is what they are saying. So we discussed it again in the routine video section, basing on the capnography. What could be it one? So this is a typical of bronchospasm. The bronchospasm, or if there is partial obstruction to the endotracheal tube, partial obstruction to endotracheal tube. This is what we discussed in the classroom. So yes, I don't know if there was any change in the ECG, because I don't know, many students have not commented on the ECG, how it was looking it very particularly. But some students, they said they have given capnographic waveform. I am not very sure if I am wrong or right. So if they have given this waveform and they asked you this question, so it's a straightforward answer. It's a acute bronchial asthma. Right? Bronchial asthma is a bronchospasm where there will be narrowing of the airways will be there. So there will be, in the capnographic waveform, there will be increased upstroking of the phase 3. This is phase 1, I said, phase 2, phase 4, or some people call it as phase 0. Okay, phase 1 is the gases exhaled from the dead space gases, which we discussed. So that's always touching to the baseline. That's a baseline, phase 1. Phase 2 is the inspiratory upstroke, where the gases start exhaling from your upper alveoli. Phase 3 is the phase, there will be slight amount of, normally if you ask me what is the normal curve, you all must be knowing it. So there will be slight upstroking. For a normal patient, there will be slight upstroking. If there is an increased upstroking, then definitely it is a bronchospasm. The slight upstroking is due to the difference in the size of alveoli from the middle and lower alveoli. Okay, we discussed it in detail. I'm not very sure about this question. That's the reason why I kept it wrong. So if there is any discrepancy, or I don't know, if they have asked some ECG and they are particularly pointing about ECG, I don't know if it comes under medicine or anesthesia. So that's the reason why I kept it last. So if there is any change, just do ping me. I will answer that question if there is something which I have missed out. So these are 3 or 4 questions. There was one more question also, then basing on the Allen's test they have asked. Again, that will be covered in your surgery. I don't want to repeat it, and I don't want to make this session lengthy. So by this time, you must be tired. I know everyone is tired after writing this examination, and some students are, happy they wrote well. Some students are not very happy. They wanted to recorrect. They wanted to, they kept a lot of hopes on this examination. We don't know what exactly is happening. So what I can suggest is, like, one thing is very clear. When you are preparing for this examination, definitely this might be the curve. No student curve will be a straight line like this. Okay, this image I felt very close, right? When you are preparing for this examination, no student curve will be like this. Sometimes you will be having ups and downs in your preparation part. Sometimes you write exam very good, sometimes you don't write the exam very good. It's all okay, but at the end of the day, this system of examination is like this. If we can learn from our mistakes, that would be a very good thing. So while looking for this position, make sure you enjoy this position. Okay, so I don't say this is, some students are really depressed. Of late I'm getting a lot of messages from the students saying that, sir, we thought this exam we will crack this one, but somehow we couldn't do it to our level best of thinking. So I can only say that this part you have to work like this. You have to start preparing. You have to look at the previous year. What are the areas, especially from anesthesia, the areas which are really important are the areas. These are the standard questions, from ventilator settings for an basic life support, capnographic waveforms, or pre-anesthesia checkup. So these are the standard questions what they have scheduled. Hope this session helps you prepare well for the upcoming examination, and those who have written well, yes, do ping me with your answers if there is any discrepancies in the questions what you have noticed later. So with this, I will conclude this session. Wishing you all the best. Seeing you on the other side. All the best, students. Don't worry, this is one examination. You can prepare very well also. Okay, fine. Thank you.